Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome Dr. Shiva Arul Selvan. Sir is MBBS MD DNB Endocrinology, consultant endocrinologist at SNHRC Vellore. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is approach to a child with mild TSH elevation. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Okay, thank you. Respected colleagues, in the next 20 to 25 minutes, we'll discuss how to approach a child with mild TSH elevation. Should you be worried about this condition or is it a benign condition? So the brief answer is no. Mostly it is not a worrying condition. Mostly need not worry. So we'll discuss why the answer is no in the coming slides. So first we'll see what is mild TSH elevation. Is there any definition for the same? So mild TSH elevation is part of subclinical hypothyroidism. Subclinical hypothyroidism is otherwise called mild hypothyroidism or mild or early thyroid failure or compensated hypothyroidism. By definition, it is subclinical, so it is a biochemical entity. The patient usually does not have symptoms, but sometimes they can have. And it is defined as a TSH levels which is greater than the upper limit of the lab reference range in the presence of normal T4, either a total T4 or free T4. So TSH elevation in the setting of normal T4, that is called subclinical hypothyroidism. And the levels cutoffs are slightly different in the neonatal period and children. The neonatal period that usually it is called subclinical hypothyroidism, and the TSH levels are between 6 to 20. TSH are usually elevated in the first 2 to 3 days. It can go up to 20 to 25. After 5-6 days, it is usually less than 6. When the levels are persistently elevated between 6 to 20, the neonatal period up to 1 month, you call it subclinical hypothyroidism. And after the neonatal period, in the childhood period, when the TSH is above 4.5 with a normal free T4, you call it subclinical hypothyroidism. So SCH in children, we have two categories. One is mild TSH elevation when the TSH is between 4.5 to 10, and another category is marked TSH elevation or severe TSH elevation, which is TSH more than 10. The second category that is TSH more than 10, mostly there is agreement that you should treat these patients. Only when the TSH is mild elevation, that is 4.5 to 10, there is not much agreement whether to treat or not. So we'll discuss this mild TSH elevation category. So just to revise, mild TSH elevation is a very SCHSL's mild hypothyroidism, and mild TSH elevation is the mildest form of SCH. That is TSH between 4.5 to 10 with a normal T4. And we are not going to discuss when the TSH is more than 10 because mostly we will treat when the TSH is more than 10. So when the TSH is between 4.5 to 10, what to do with the child? So we'll see how common is it and what are the causes for this mild TSH elevation and what are the precautions when you treat the patient or when you follow up the patient, and what are the clinical course of the mild TSH elevation? How does it evolve over a period of time? And what are the clinical consequences? Does it have any adverse clinical effects? And finally, how to manage these patients. So how common is mild TSH elevation or subclinical hypothyroidism? Okay, it is quite common in adults. In adults, the prevalence may be between 5 to 15%. So on an average, 10% of the adult patients can have mild TSH elevation. However, it is not common in children. One study from Delhi has noted a prevalence of up to 7%, but all the studies have noted the prevalence is between 2 to 3%. So it is not very common in children. However, if you happen to see a child, you should know what to do about the patient. And what are the causes? Does it always mean the thyroid is failing? Is it a sign of thyroid failure always? Not always. There are thyroid related causes and non-thyroid related causes for mild TSH elevation. So what are the thyroid-related causes for mild TSH elevation? Most common cause is mild autoimmune thyroiditis. It is not common in the early childhood. In the infancy, in first 2 to 3 years, it is not common. And the usual age group, it is between 8 to 18 years. So mild autoimmune thyroiditis, they can have mild TSH elevation. Some may progress to overt, some may remain mild TSH elevation. And secondly, we can have mild developmental anomalies. A marked thyroid developmental anomaly usually presents with congenital hypothyroidism, whereas mild abnormalities like mild thyroid dysplasia or mild enzyme defects can have mild TSH elevation. Like DOX2 mutation, it is an important cause for mild persistent TSH elevation in children. This enzyme is important for tyrosine iodination. And sometimes there could be a receptor in TSH which can cause TSH elevation. And if the child has a history of head and neck radiation due to some malignancy like lymphoma or head and neck cancer, that can also cause TSH elevation. And syndromes like Down syndrome, Turner syndrome, they can also have TSH elevation. These are the thyroid gland related causes. And that could be non-thyroidal reasons for mild TSH elevation, like obesity, Addison's disease, some of the drugs like anti-epileptic drugs, interferon alpha, which is used to treat hepatitis C or hepatitis B. So some of the and amiodarone iodine containing drugs, this can also cause mild TSH elevation, and sometimes there could be no reason, just a random variation. Just a word about TSH and obesity. Many times, obese child TSH is tested, and TSH is found to be mildly elevated, like 6, 7. And many times, that both the doctor and the patient puts the blame on TSH. Actually, it is the reverse. TSH elevation in obesity could be the consequence of obesity rather than the cause of obesity. Up to one fourth of the patients with obesity can have mild TSH elevation, and the elevation is not causing obesity. Actually, obesity is causing TSH elevation, and usually the TSH falls when the patient loses weight. There are some postulated mechanisms why TSH elevated in obesity. Leptin can stimulate the TRH, and TRH can cause TSH elevation, and that could be decreased responsiveness of T4 and T3, so there could less negative feedback, so TSH can be elevated. Whatever the reason, many times the TSH is a consequence of obesity rather than the cause of obesity. So don't jump and treat a mild TSH elevation in obese patients. Just a simple weight loss will cause normalization of the TSH. And there are other non-thyroidal causes like nephrotic syndrome, food-related causes, endocrine disruptors. Sometimes there are studies shown that prolonged mobile phone usage can also cause mild TSH elevation, or it could be no reason, it could be idiopathic TSH elevation. So mobile phones emit radio frequency electromagnetic field radiation. It's a form of non-ionizing radiation. And because of the location, when the patient keeps talking through the phone, thyroid gland is one of the most susceptible organs because of the location. There are some association between prolonged phone usage and TSH levels alteration. Some studies have shown that TSH can go up. Some studies have shown that TSH can be suppressed. Usual reason is mechanical damage. The histopathology changes have noted that there is a decreased size of thyroid follicular cells, decreased volume of thyroid follicular cells. So there is some form of apoptosis going on because of the radiation. That is why there is some amount of TSH elevation. Again, there is no conclusive proof, but these are all possible reasons. So what are the cautions when you see a patient with TSH before you decide whether to treat or not? So it could be just look at the reference range, because there could be different reference range for different age group, and there could be lab to lab difference in reference range. And there could be a circadian variation. TSH has a circadian pulsatile secretion between day and night. So different times can also cause different TSH levels. Usually the peak is between 2 to 4 a.m. in the early morning, and the nadir is between the late afternoon or evening between 4 to 8 p.m. So what time we check can also affect the TSH levels. So altered cycle can also alter the circadian variation. And there are studies have shown that TSH levels could be different in different seasons. Usually the studies have shown that it is slightly high in the winter and slightly low in the summer. Again, there is no specific reference range for different seasons. And food can also affect the TSH. After food, TSH can slightly become lower. postprandial levels of TSH are slightly lower than the fasting levels. And there could be inter-assay variation. So different labs can have different values. So, and there also, the labs are not standardized, can have lab errors. And there can also biological variation, intra-individual variation. And it could be just a statistical variation. So these are all common reasons you look at before making diagnosis of hypothyroidism. And whenever you see a patient with mild TSH elevation like TSH of 6 to 7, but the free T4 is markedly low, then that is not subclinical hypothyroidism, that is pointing towards central hypothyroidism. When the free T4 is very low, in primary hypothyroidism, TSH will be markedly elevated. So in the setting of markedly low free T4, when the TSH is not grossly elevated, only if it is mildly elevated, that points towards the central hypothyroidism, that is more serious disease. You should evaluate other pituitary functions, pituitary MRI, whether the child is having any craniopharyngioma, etc. So that needs a detailed evaluation. That is not a simple subclinical hypothyroidism. So what happens over a period of time? What is the natural history of subclinical hypothyroidism? There are three possible outcomes. One thing is that it can progress to overt hypothyroidism, or the child may continue to have persistent subclinical hypothyroidism, or it can become normal over a period of time. It can become euthyroid. So what is the data showing? How common is the progression, or how common is reversal? Most of the studies looking at this data are retrospective with small sample size, and the follow-up duration is variable between 2 weeks to 9 years. Most of the studies it is between 3 to 5 years. And the TSH cutoff used in the studies are different. So different cutoffs have been used. So there is no very hard data, but whatever the data we'll see. These are the various studies which are looked at what is the natural history of mild TSH elevation in children. So the sample size has between 29 patients to 322 patients. Only one study has looked at very large population, more than 1 lakh, from study from Israel. And the duration is between 2 to 5 years. So what are the outcomes in this study? So what are the chances that the mild TSH elevation will progress to overt hypothyroidism? This is a summary of all the studies, except for one study which is more than 1 lakh. Most of the studies very small sample size, between 90 to 300, and the follow-up duration is between 2 to 8 years. As you can see, the chances of overt hypothyroidism is very low. Most of the studies, overt hypothyroidism is 0%. Only 2 studies have shown that it is 12% or 13%. Again, TSH going more than 10 is also very low. Data is available only for few studies. Whatever data is there, it is usually 2% or up to 10%. What are the chances that the mild TSH elevation can become normal? Again, all the studies looked at the chances of becoming TSH becoming normal is quite high. At least 1/3 to 2/3 of the babies, if you follow up, it will become automatically normal. So there is high chance that it will automatically become normal over a period of time. So to summarize, the natural history is most of the child with mild TSH elevation, they can continue to have mild TSH elevation, or they can go back to normal. The risk of overt hypothyroidism is very low. So that is a reassuring finding. So what are the reasons for reversible mild TSH elevation? Why does the child have transient TSH elevation which becomes normal automatically without any treatment? One reason could be that this recovery from non-thyroidal illness. Any acute illness like pneumonia or head injury or whatever, during that acute illness, everything will be low. TSH, T4, T3, everything will be low. And when they recover from this acute illness, there will be a shoot up of TSH from low to high, and it will automatically become normal over a period of next 3 to 4 months. So when you check the TSH during the recovery phase, you may find it is mildly elevated, which will become automatically normal during treatment. Again, subacute thyroiditis or any form of acute thyroiditis, during the acute phase, they will have low TSH, and during the recovery phase, they will have high TSH, and again, it will become normal over a period of 3 to 6 months. And as I said, obesity is the reason for mild TSH elevation, and many patients with Addison's disease can also have TSH elevation, which will become normal when you treat the Addison's disease with steroids. And drugs, as I said, like iodine-containing drugs, iodine contrast, amiodarone, some anti-epileptic drugs, ATT, these also can cause mild TSH elevation. And it could be a lab error. When you recheck, it will become normal. And mild autoimmune thyroiditis can also have persistent mild TSH elevation or reversible TSH elevation, or it could be just a random variation. These are the causes for reversible TSH elevation. So what are the consequences? What are the potential worries when you see a patient child with TSH elevation? Potential worries are whether it will progress to oat hypothyroidism, whether it can affect the child's height and weight, whether it will cause cognitive deficits, neuropsychiatric problems, and whether the child can have delayed puberty, whether it will have bone or abnormal bone health or cardiovascular disease. These are the potential worries in your mind when you see a patient with TSH elevation. So if you don't treat, whether it is harmful, whether if you decide not to treat the mild TSH elevation, it is whether it is going to harm the patient. So mostly it will not harm if you don't treat. Untreated suckling hypothyroidism don't progressively gain weight. It is not a cause for progressive obesity. And long-standing suckling hypothyroidism is not usually associated with during height velocity and bone maturation. So mostly it will not affect the height. So the child will not end up in short stature. And most of the studies have shown that it is not going to affect the puberty. Most of the child with mild TSH elevation, they will enter a normal puberty just like any other children. And studies and IQ studies have shown that mostly they will have normal IQ as for any other children. One study have noted that they may have some attention span deficit, but most of the studies have shown that they will have normal IQ just like any other children. So mostly if you don't treat, it is not going to harm the patient. And in adults, one of the common reasons to treat is the increased risk of CVD. In adults, it is shown that mild TSH elevation over a period of time can increase the risk of cardiovascular disease because of dyslipidemia, hypertension, etc. But in children, there is not sufficient data to say this is a reason. So preventing CVD is not a reason to treat a child with TSH elevation. There are some pointers like mild homocysteine elevation, mild dyslipidemia, but there are no hard data that it will cause CVD in the long term. So this is not a reason to treat a child with TSH elevation. So suppose you, whatever reason, decide to treat the patient, are there any benefits in treating a mild TSH elevation? There are no RCTs to say whether it is beneficial or not. Most of the retrospective studies have shown that there is not much benefit in treating a mild TSH elevation. Most of the time, the child is not going to lose weight. It does not help in obesity. There is no change in weight. And most of the child, they grow whether you treat or not in the good growth velocity. And there is no changes in the neuropsychological outcomes also. Two studies have noted that that could be a slight increase in growth velocity. And one study has noted that there could be reduction in the size of goiter. So if you find a child with TSH elevation, no other reason, but child has short stature, so that could be good reason to treat because you don't have anything else to do. And the patient has goiter, that can reduce the goiter size. So that could be another reason to treat. So if you treat whether any harmful, is it treatment, whether treating with thyroxine, is it going to harm the child? Usually it's not going to harm as long as you keep the TSH in the normal range, appropriate dosage. If you give very high dose and cause TSH suppression, that is iatrotoxicosis, that can harm the child in long term. So don't overdose the thyroxine. If you decide to treat, keep the TSH in the low normal or mid normal range. Don't suppress the TSH. And another harm, if you treat the patient, is the parental anxiety. Once you start the drug, patient thinks there is some serious disease. They keep on checking the blood test at different labs at every 2 to 3 months. So they can have parental anxiety. And many times mild TSH elevation is not the you may find a mild TSH elevation, but that may not be the actual explanation for the child's symptom. Child may have some other problem, and you file a TSH elevation, you chase the TSH, and that is not going to solve the problem. So actual problem may be missed when you focus on TSH elevation. So what to do, how to manage? We'll see what to do in neonates and what to do in children. What to do in neonates and children, infants up to 2 to 3 months. Definition is between TSH 6 to 20 with a normal FT4. The free T4 is low. Most of the recommendation is to treat whatever the TSH levels. So free T4 is low, you treat the child. Free T4 is normal and TSH is mildly elevated between 6 to 20. What to do? This can happen in very preterm child, ill, sick babies, or small for gestational age, IVF babies. And in this child, the TSH can get elevated at a delayed time and they can become normal automatically. So most of the child will need second screening at 2 weeks or maybe a third screening at 4 to 6 weeks in this very sick child. And one thing you can do to decide whether to treat or not is imaging. If you have imaging like technicians or thyroid scintigraphy, that will give a clue. If you find any thyroid dyshomogenesis or thyroid dysgenesis, that is a definitive reason to treat. If you have thyroid hypoplasia or ectopic thyroid, that is a definitive reason to treat. So if you have imaging, better to do it so that we can make a quick decision whether to treat or not. And many times, even in the neonates, it is only a transient elevation. If you follow up the neonate, it will progressively become normal. Only 1/3 will have persistent TSH elevation without any progression to overt hypothyroidism. So what to do? The TSH remaining between 6 to 20 in a baby even after 3 to 4 weeks. There are two approaches. Either you start treatment at the time and interrupt treatment at later stage, usually after 3 years, and decide whether to continue treatment or not. Or if you are not, or if you don't want to treat, you can keep checking the TSH every 2 weeks. If it is progressively coming down, you don't have to do anything. If it is progressively going up, then you start treatment. If you start treatment, better to continue treatment for up to 3 years, because for 3 years is the important time for brain development. So after 3 years, you can stop and see whether it is resolved or not. So either start treatment or keep checking every 2 weeks. If it is progressively coming down, you can just reassure the patient. If it is progressively going up, you start treatment. So what about in children after the neonatal period? As I said, rule out non-thyroidal reasons like obesity, Addison's disease, any drugs, any other transient causes. And don't jump and treat in the first instance. Repeat the test after 2 to 3 months, whether you see to see whether it is transient elevation or persistent elevation, and look for any cause like autoimmune disease, any other history of neck radiation, neck surgery, etc. And mostly it is asymptomatic. Some child have symptoms. So incur any child has any symptoms. The treatment is based on the etiology, the degree of TSH elevation, and the risk of progression toward hypothyroidism and presence of symptoms of thyroid impairment. So when you assess the patient, look for whether it is child is having TSH elevation since the neonatal period. That is called persistent neonatal TSH elevation. That is a benign condition. And Hashimoto's thyroiditis is the most common cause. So look for any other associated autoimmune disease like pernicious anemia, diabetes, anything else. Look for any genetic disorders like Down syndrome, Turner syndrome, etc. Whether checking any drugs like anti-epileptic drugs and anti-tuberculosis drugs, etc. Does he have any symptoms? Look for goiter. Look at the growth parameters, growth centile, height centile, weight centile, and other syndromic features. And what the test you do? First time the child will come, parents will come with the reports of TSH and T4. When you find that it is mildly elevated and no other reason, repeat it after 2 to 3 months. And at the time you check for thyroid antibodies, TPU antibody. And ultrasound is not required always. If you find a goiter or nodule, you can check ultrasound. And if we have a thyroid scintigraphy, that could also be done in very young children to rule out whether it's a thyroid dysgenesis. And what are the factors associated with progressive TSH elevation? So if these factors are there, a reason to treat. The baseline TSH is above 7.5. There are high chances it will progress to more than 10. And female gender, markedly elevated thyroid antibodies, but it's more than 3 times elevated from the upper limit. And presence of other autoimmune disease like diabetes, pernicious anemia, rheumatoid arthritis, whatever autoimmune disease is there. And if there's a family history, then that is also been noted to have a progressive TSH elevation. And if we keep checking the TSH is getting elevated every time, that is also a factor for progressive to overt hypothyroidism. So when not to treat a child with mild TSH elevation, the TSH is between 5 to 10, no symptoms, no goiter, no other explanation, negative antibodies, and no specific cause. So in these patients, you can just wait and watch. So when to treat, the TSH is more than 10 or TSH is between 4.5 to 10, and the child has some symptoms of hypothyroidism, or the child has goiter, and the serial TSH is showing progressive elevation. There are multiple risk factors like these are the risk factors I mentioned: baseline TSH, elevated antibody, family history, etc. There are multiple risk factors for progression. Or if you find a specific cause like the history of head and neck radiation or the antibodies are positive, then you decide to treat. TP antibody positivity. And some doctors decide to treat in the first 3 years because they don't want to take risk in the phase of brain development. Or when you find the patient has a decreasing growth velocity and no other explanation is there, then to be on safer side, you can treat that child also. So if you don't treat and how to follow the child, so monitor the TSH every 6 to 12 months for first 2 years. And if the TSH is stable and the antibodies are negative, then maybe clinical follow-up will be sufficient. If the antibodies are positive, better to check the TSH at least once a year, or if it is stable, at least once in 2 years. So if you treat, how to follow, keep the dose appropriate, don't suppress the TSH, avoid iatrogenic toxicosis. And if there is antibodies are negative, then it could be transient. If you treat, you may stop treatment after 1 to 2 years and see whether it is resolved automatically. So if it is again going up, then you decide to treat lifelong. So this is the overall approach. The TSH is elevated above the normal and free T4 is normal. That is called subclinical hypothyroidism. The TSH more than 10, there is mostly agreement to treat. If it is TSH less than 20, repeat maybe after 2 to 3 months. If it is again less than 10, look for the causes as I mentioned, antibodies, history of neck radiation, any drugs, acute illness, etc. And these are the factors which will increase risk for TSH progression. Presence of goiter, female sex, elevated TP antibodies, other autoimmune disease, etc. And you closely follow the child for every 3 to 4 months initially, 3 to 6 months. TSH is progressively increasing, then you can decide to treat. If it is stable, just clinical observation should be sufficient. So this is the overall approach. So further take-home messages, mild subclinical hyperthyroidism or mild TSH elevation is usually a benign problem in children, and it is not usually the reason for the child symptoms, whichever prompted the reason for testing. So look at the other, don't miss the main problem. It could be just a incidental finding. And TSH elevation obesity is it's a consequence rather than cause for obesity. And mild TSH elevation is mostly remains stable or reverts to normal in most of the children when you follow the patient. And there is a very only very low risk of progression to overt hypothyroidism. So we'll stop with this. If there are any questions, we can discuss. Yes.
Thank you so much, sir, for your wonderful presentation. We do have some questions from our audience if you'd like to take that up.
Yes.
Yeah. So, sir, the first question is, when should a repeat TSH test be conducted and what additional thyroid function tests are required?
Yes. The main reason to repeat TSH is look at whether it is a transient elevation or persistent elevation. So usually the recommendation is you can test after 6 to 8 weeks or 2 to 3 months. Or when the child is going to get blood test for any other reason in the coming weeks, we can test it along with that. Usually it will be 2 months or 6 to 8 weeks. At that time, you can check the thyroid antibodies, either TP antibody alone or TP antibody and thyroglobulin antibody. And you also check the free T4. So the definition is normal elevated TSH with normal free T4 is called subclinical hypothyroidism. So check TSH, repeat TSH, free T4 and thyroid antibodies after 6 to 8 weeks.
So the next question is, how should a pediatric patient with mild TSH elevation and a family history of thyroid disease be managed?
The family history means there is a slightly increased chance for progression of TSH in the coming years. Management is same. You monitor more frequently every 6 months in the first 2 to 3 years. If it is progressively increasing, you decide to treat.
So there's one last question. How should mild TSH elevation be managed in the context of other chronic condition in a child?
Other chronic conditions, a broad question. If it is associated with autoimmune disease, then the chances of progression is high. So you decide to treat like chronic conditions like type 1 diabetes, pernicious anemia, any inflammatory arthritis. So coexistence of autoimmune disease is an increased chance for progression. So there you decide to treat. Other chronic disease, I don't think there is any specific protocol. You decide according to the individual patient.
Thank you so much, sir, for answering all our questions. That's all from our audience. So, sir, before
Okay.
concluding, any last message from your end?
Yeah, many times the mild deceleration is an incidental finding, and the child symptoms may be due to some other reason. So many times the doctor focus more on TSH elevation and misses the actual problem. So just keep the TSH aside and look at any other explanation for the child symptoms. So treat that. Then we can come to the TSH. Don't put everything on the TSH and miss the main problem. That is one important message I want to tell.
Thank you so much, sir, once again for joining us today. And with your permission, sir, I would like to conclude today's session. Thank you.
Okay. Okay. Thank you.